Thank you so much, Isabel, for inviting me and giving me the opportunity to speak. Let's hope I have more luck with my slides than Kamran. Let's see. Okay, Isabel already mentioned some of my affiliations, and I think that is important because it might be conceived as a conflict of interest as well, because I'm going to speak in part about what Cochrane is doing in that field. Some of the work I will present received funding from the University Medical Center in Freiburg, but I don't have any, I'd say, direct conflict of interest financially. So I'm not head of a startup or I'm not investing in any kind of AI company. And special thanks, that's important to note, to some of my colleagues at my university, but also in the Cochrane AI methods group who have provided some slides, which I'm going to show. Okay, so what is the plan for the next 35, 40 minutes? So a bit of background, although we have heard a lot on AI already, but I'll try to focus that on evidence synthesis. Then I'm going to drill a little bit into LLMs because I think they are right now the kids that are going through town, but it's also the one where the most research currently lies in the field of systematic reviews. Then I quickly talk about the issue of a reference standard, which I think is really important for evaluation of AI in our field. And then I'll speak briefly about risks and challenges, and then some guidance that Cochrane and others are developing in relation to AI use for systematic reviews. And then I'll close with a summary. So let's get started. I assume that the process of systematic reviewing the evidence is somewhat familiar to most of you. And that relies for the last 30 years on three important principles, namely rigor, transparency, and replicability. And I think it is very important to understand that it would be totally unfortunate for the evidence synthesis community to risk losing that understanding, that evidence synthesis, systematic evidence synthesis really is rigorous, transparent, and replicable. So what are the steps that we usually follow when doing a systematic review? And again, many might be familiar. I'm just very quickly laying those out. It starts with defining a very precise research question. Then based on that definition of inclusion and exclusion criteria, and we often use that PICO acronym for that. Then it's the definition of the methods, then the actual searching, the systematic identification of studies, then the screening process, data extraction, bias assessment, so the quality, trustworthiness of the individual studies that are going to inform the systematic review, then the analysis and interpretation of the results, and eventually an update of that review. There are two important steps in that process. So first of all, once the research methods have been defined, usually a protocol is being published, and then eventually the full review is being published. But the issue has been for many, many years that it's way too slow. The way we handle our things, and in particular within Cochrane, the time from publication of a protocol to the publication of a full review, you see some figures here, mean duration 67 weeks, and in fact, I think in the past couple of years, it has been more than that. So based on that, I think it's quite understandable that it's quite tempting to think about use of artificial intelligence to support some of the steps, just to become quicker and more efficient in what we do. And this is not new, but it goes back actually, I wouldn't say since the beginning of Cochrane, but at least for the last 10, 15 years with machine learning algorithms, that people starting to think, can we identify RCTs more easily through machine learning approaches? And more recently, can we use other more modern machine learning approaches and more recently large language models to actually improve what we are doing? And this is a scoping review, which was done, a methodological scoping review some time ago in 2022, and I think the search dates back to 2021, where surprisingly many tools were already on the market for very specific tasks in our field. And it's not important to look at the individual tools that were available. It's just to understand that people were actually trying to develop tools for the different steps, usually just single steps, not a whole suite or not a tool that could cover all the steps at once, but different steps. But still, I think most of the tools, while being piloted in single reviews, haven't really transformed the way we do evidence synthesis so far. Although some of them actually have been implemented in software platforms that we are using for our work. some of you might have worked on systematic reviews, and a software that is very prevalent here is Covidence, which is being used primarily for the screening process to support and make it more transparent, the screening process, but also data extraction. And if you look thoroughly, there is actually the option implemented within Covidence for quite some time, which allows us to rank your screening results by relevance. And that actually, underneath that, there is a machine learning approach which increases the predictive value of the ranking through the screening process that you are actually doing. So there are elements of AI that we are already using, sometimes without even noticing really. But again, I think so far that really hasn't dramatically transformed what we are doing. So let me talk a little bit about the large language models, because there's really a lot happening in that space. I think I don't need to go into the details of artificial intelligence, maybe except to say, and that is why it's so attractive, that there is no task-specific training necessary, and I think that is important. And they can be used without specific programming knowledge. And again, that is what makes them so attractive to people like myself. I'm a trained pediatrician, I'm not a tech person, but I can use large language models much better than classical machine learning algorithms and program them myself. Okay, so there is a lot of excitement in the field, but at the same time, a lot of uncertainty, because we just don't know how to use them and whether they are good enough to be used at scale, for example, within an organization like Cochrane. But they hold a lot of promise in terms of speed, in terms of scale, if they work, and also in terms of breadth of topics that we might be able to cover. So, my prediction is that LLMs will have an impact on our community. Whether it will be more on the innovation side or more on the disruption side is something I think we need to figure out. It's, I think, foreseeable that we will be able, through the use of large language models, to do the same things maybe a bit better and faster, potentially doing new things as well. And what needs to be seen is whether we'll be doing new things that make the old things obsolete. And given that we have that kind of continuum of change, it's, for now at least, quite difficult to figure out where to focus our efforts. And as we're going to see, primarily for the time being, I think it's just trying to do the things that we have been doing in a conventional way somewhat better. This is a figure from a scoping review which Angelika Eisele-Metzger from my team did about a year ago. And she basically systematically identified research papers that used LLMs for any single step of a systematic review process. And as you can see on the bottom, there are the different steps which I basically described to you earlier on. And then the different publications are ranked according to the author's conclusions. So basically self-assessment of the authors, whether they felt that the results were promising, neutral, or non-promising. And I think what can be seen is that there are some clusters within that research area, right? So it's often used apparently for screening so far. There's a second cluster in relation to data extraction, and potentially a third cluster in terms of the searching and identification of studies, which isn't as promising as the other two. But I think just based on that kind of research landscape, it would be too early to advise people that it's safe to use AI to support the systematic review. But before I come to the evaluation piece, I just want to quickly give you some examples which might indicate the promise that some of these approaches might hold. So one here is basically framing of the research question, or identification of relevant research questions. And that's a piece of work that I wasn't involved in. Obviously, it's on plastic surgery research. And what they did is they just asked ChatGPT for novel systematic review ideas. So areas where it might make sense to do a systematic review, because sometimes it's actually quite difficult to come up with an original, relevant research question for a systematic review. And I think they asked ChatGPT that specific prompt a couple of times, so that they overall created or asked ChatGPT to create a total number of 240 ideas. And then manually they classified and searched whether those ideas are already covered by traditional narrative reviews, by systematic reviews, and whether that, based on that assessment, actually is a novel, unique idea to do a systematic review. And overall, apparently ChatGPT was able to come up with 132 novel ideas which haven't been covered in systematic reviews, but where there are trials or at least observational studies available. So that might be just a good starting point, and that's much quicker than doing that piece of work yourself. Another example, so I'm not talking about the screening because I think Professor T is going to cover that in his presentation. So the next example I want to quickly present to you is data extraction. That's a work that was published by Gerald Gartlehner from Cochrane, Austria, about a year and a half ago, where they did some first steps in trying to use Claude, or another large language model, to support data extraction. And they used Claude 2 at the time in extracting data elements from 10 published studies and compared that with their human extraction, which they already had done as part of a systematic review. They used pretty simple prompts, which are nicely described, transparently described in the paper. And what they found is that in instances where data were available, Claude 2 successfully extracted the information with a sensitivity of 96.2%. So 151 out of 157 cases. And very few major data extraction errors, basically. So that, I think, was quite promising, really. And later on, I'm going to show you a follow-up study that they did. We in Freiburg, we tried to use Claude 2 again for risk of bias assessment, something that is certainly tricky because it requires a lot of judgment. So it's not as obvious and clear-cut as data extraction. And we fed all the lengthy guidance that is available for risk of bias version 2 available to Claude, and then asked Claude to assess the bias for 100 randomized controlled trials, which were included in Cochrane reviews. So we took the assessment within the Cochrane reviews basically as our reference standard. And those are the results. Agreement between Claude and Cochrane authors ranged between 41 to 71%, so not really that promising. But keep in mind, and I'll come to that in a second, that we are not absolutely sure that the Cochrane authors, or we cannot be absolutely sure that the Cochrane authors assess the risk of bias appropriately. So, a last quick example, plain language summaries. Again, that has a long history within Cochrane that we think that we need to communicate our findings in a way that they are understandable also to the lay public and decision makers. And that has been a struggle within Cochrane for many, many years to come up with appropriately phrased plain language summaries. And this study used ChatGPT to improve the readability and linguistic characteristics of 275 Cochrane PLS and about oncology interventions without changing evidence synthesis conclusions. So this is a prompt that you can see here. And again, it worked reasonably well. So it improved, and there are some tools to assess readability. It reduced analytical tone and increased authenticity, cloud, and emotional tone compared to the original PLS, where already people tried to write a PLS. So it wasn't the abstract, right? It was the PLS that people came up with. So again, I think there is some potential here. And now one of the larger, very recent studies, which I think is a step forward from the initial 4 examples, which are basically just playing around with the large language models and trying what they can potentially do. And this is one of the first studies that I believe really moves into a more thorough evaluation. It was just published a couple of weeks ago in the Annals of Internal Medicine. So it's a study within a review, a SWOR. It's prospective, it's parallel group comparison with blinded adjudicators. The objective was to compare AI-assisted and then checked by a human data extraction with traditional human-only data extraction by 2 reviewers. It was a workflow validation within 6 ongoing systematic reviewers, so it was prospectively done. And they identified 9,341 data points, which were then initially extracted by Claude again, and then verified and checked by a second investigator. And they also had a series of outcomes that are familiar from diagnostic test accuracy designs, concordance, accuracy, positive predictive value, but also, quite interestingly, time on task and error analysis. So a very thorough piece of work. Let's look at some of the data. So these are just the data from the AI-assisted approach. Right? And if you want to focus on the last line, you can see that I'll just focus on the right-hand corner, the true positives, false negatives, and true negatives. Wherever there was information available, actually, Claude was able to identify most of that information. There are only a few false positives, where basically Claude came up with some information that wasn't really in the data. There's a bigger number of false negatives where apparently Claude wasn't able to extract that information from the original study report. But still, if you look at the other parameters, accuracy, sensitivity, positive predictive value, that's actually pretty good. And it remains to be seen how humans actually did in comparison to the AI-assisted approach. And that, I think, is very, very impressive. Because as you can see, basically for all the parameters, the AI-assisted approach, so not pure AI, but AI-assisted approach, was as good or even better than the standard human approach. And the team in Krems in Austria really is an experienced review team, right? They know what they are doing. It's not that it's an unexperienced team that does some data extraction. And if you then add to that the time saved, and that is the comparison for the individual review, and at the bottom for the summary of all reviews, on average, it saved about, 40 minutes per extracted study at the same accuracy. Okay, so I think that is impressive and that's encouraging, but clearly we need to make sure as a community that we are using AI responsibly and transparently. And right now it feels a bit like this, and many of you might have seen a similar picture because it has been used by Ian Chalmers, the founder of the Cochrane collaboration, I believe, already 30 years ago when Cochrane was started basically and established, because setting up that organization felt like building a plane while already flying it. And I think we are right now in a kind of similar situation where AI is being used by people. There is a strong push to use AI, also by funders, because they want to get the results quicker and cheaper. But at the same time, we need to figure out how to use it responsibly. Okay, so let's quickly talk about reference standard. I already told you that the standard study design that we use, obviously, when evaluating AI tools is a diagnostic test accuracy design. And the reference standard for most of the papers that have been published so far is human screening, because that's what we've been doing for 30 years, and that's the best standard that we have, experienced screeners or reviewers. And the index test is, for example, the large language model for screening. Most of the papers so far apply that retrospectively. There are very, very few studies which do it prospectively, like the one by Gerald Gardner, which I just showed you. But I think that is what we need. We need to prospectively evaluate how good the LLM tools are. People have agreed, again, based on standard diagnostic test accuracy designs, on relevant parameter to report. And again, unfortunately, that is not the case for all the studies that have been published so far. And I think as a community, we need to get much better in reporting consistently our outcome parameters so that we also can compare across tools rather than just relying on a single piece of research that advocates for use of a given tool. Still, while having figured out how to do the studies and what to measure and what to report, we need to come to a consensus on what actually is our expectation in relation to the reference standard and what are we actually aiming for in our studies. So usually, I already made that point, it's a human reference standard. But we know that that human reference standard isn't really good. This is just a single paper, and there are a few more than that, who has shown that across reviews, and it wasn't all Cochrane reviews, it was other reviews which often are of a somewhat lower quality, the rate of extraction errors was up to 50% in some of the reviews. Same is true for bias. There are actually quite a few papers out there which show that agreement between reviewers or teams of reviewers in relation to bias assessment is bad, right? It's not good at all. So human performance is far from perfect. So we really need to discuss and agree what is our expectation for AI before we accept AI to support us in doing reviews. Is it really the dual pair of reviewers, which has been used so far, or do we need to increase our, eventually at least, should we increase our expectation in terms of reference standards? So, for example, I'm just making that up, 6 very experienced reviewers. Should that be our reference standard? Or would we even want to have a perfect reference standard, however we gonna achieve that? And then it's not that's the only question that we need to answer. What is the situation if you're talking about rapid reviews? Should we then consider a different reference standard acceptable, a different kind of target range? Or what is acceptable if costs are substantially lower? Right? If you can get a review for a tenth of the amount that we are investing right now, or even less, would we then accept a lower reference standard? Okay, so this certainly is a crucial thing for us to figure out. What is also within the community, the funders, the decision makers, an acceptable reference standard that we should aim for? But there are also many, many more challenges and risks with AI and evidence synthesis, and this is just a selection of those which I want to point out. Some of them have been listed before in other talks, but I think it's still very worthwhile to look at them again. So there are methodological risks. So we know all about hallucinations, the lack of transparency and reproducibility, and inconsistent judgments. There is a risk when we are using AI or LLMs, for that matter, to search or for searching and study identification risks that we might misstudy. In particular, if the training data set haven't really included all relevant reports that are potentially informative for the question at hand. Then there is a risk, obviously, with errors in data extraction or inadequate handling of cluster RCTs, for example, or time-to-event data. So far, most of the studies have looked at simple data extraction, parallel group RCTs, dichotomous data, and so on. Pretty straightforward. But we are all aware of that. Different study designs, different types of data, which are much more difficult and delicate to handle. I already mentioned the limited reproducibility, but also, and again, that has come up in relation to the rapid model evolution, right? So even if we get an evaluation right and know that a tool works well at a given point in time, we cannot be sure that it works 10 months down the line in the same way as it has worked 10 months ago. Not to mention issues around data privacy and security risk and adherence to GDPR, or the dependency on proprietary systems, which also could potentially be a huge problem for the community. But this is all just risks and challenges that we have to observe within the evidence synthesis community. There's also kind of a larger picture to keep in mind, because there might well be people, because it's just so easy to use large language models, who going to develop systematic reviews using totally inappropriate methods. And there are, if you go to, not ChatGPT, but if you go to YouTube, there are quite a few of those videos already dating back a couple of months where people promise you that you can easily do a systematic review, within an hour with ChatGPT. Right? And they look good, right? I mean, it's not that prima vista they don't look good. They're well written, they kind of fulfill the structure of a scientific article and so on. And I think we all know about the kind of predatory journals, so many of those reviews actually might end up in the published literature. Right? And that is very confusing and dangerous even, because it might end up that some of these reviews are being used for clinical guidelines. Right? And those impact healthcare. So I think that is the broader issue that we need to keep in mind when thinking of AI and the research record. So it's really a challenge to get it right for the whole research community and the whole research ecosystem. So let me talk a little bit about what Cochrane is doing in that field and how we hopefully might be moving forward and eventually getting to a point where we can use some tools responsibly and safely for evidence synthesis. So a couple of months ago, I think it was February this year, Cochrane and some other organizations in the field of evidence synthesis, like Campbell, Joanna Briggs Institute, and Collaboration for Environmental Evidence, they came together because it obviously affects all of them. It's just not an issue only for Cochrane, it's for anybody doing evidence synthesis. And they formed a joint methods group, which is being tasked with looking into use of AI, obviously, but also potentially coming up with some guidance on how to integrate AI into our processes. And one of the first initiatives was to work on a kind of position statement, very high level, which has been published a couple of weeks ago, just laying out some fundamental principles around AI use for evidence synthesis. And I highlighted the key messages here in red. I'm not going to read all of them, but and again, a few points were made by Karam earlier on. Firstly, I think, and rightly so, the evidence synthesis or authors of any research piece are responsible for their evidence synthesis, right? It's not possible to assign that to artificial intelligence. I'm going to speak about the RACE recommendations, so responsible use of AI for evidence synthesis, in a second, and they are much more detailed than that position statement. But again, the position statement already refers to that broader set of recommendations. And at the same time, one other key message is that it is okay to use AI, because it doesn't make sense to ignore it and prevent it. So it is okay to use AI as long as authors can show that it's not going to impact the methodological rigor or integrity of their research work. It needs to be used with oversight. I think that is critical. You shouldn't trust blindly and assign tasks without control to AI. And it needs to be fully and transparently reported. As Karam said for the BMJ, certainly the same is true for any evidence synthesis. Okay, so let me quickly speak about the RACE papers, responsible AI use for evidence synthesis. And for these kind of three-paper series, which is available as preprints for now, but it's going to be submitted sometime soon, quite a few organizations, and you can see just a selection of the logos on the right-hand side, came together trying to discuss and agree and come to consensus on principles and recommendations around AI use for evidence synthesis. Paper one is the high-level paper, which I'm going to speak about for a few minutes. Paper two is about the evaluation piece. How actually should we evaluate and need to evaluate AI tools for evidence synthesis? And the third paper is about selecting and using specific evidence synthesis tools for a specific use case. So, point number one I want to make in relation to the RACE guidance is that it is really comprehensive, so it's not solely about LLMs. As you can see at the bottom of that slide, it really tries to cover all areas of AI, because as we have seen, different AI approaches might be useful for different of the specific subtasks within a systematic review. Secondly, what that paper does, it lays out all the different groups or stakeholders that somehow contribute to the evidence synthesis ecosystem. So clearly it's the evidence synthesis, but there are also sometimes methodologists, AI tool developers, organizations that produce evidence synthesis, funders and commissioners, publishers of evidence synthesis, trainers of evidence synthesis methods, and users of evidence synthesis. And for all of them, there are potential recommendations available to consider when working with evidence synthesis that has used AI. And just to give you the flavor of this, these are the recommendations, again, high level, and they are underpinned by more detailed recommendations, explanations for evidence synthesis, so the authors and reviewers. Again, as I mentioned before, they remain responsible, and I think it would be a mistake to forget that as an author. And they need to transparently report their AI use in their manuscript, and they also need to ensure the ethical, legal, and regulatory standards are adhered to when using AI. And finally and fourthly, they are part of the larger ecosystem, which I just mentioned, and they need to contribute that as a whole, as a community, we can evaluate AI so that it's safe to use eventually. Very briefly only, the paper 2 is about the evaluation piece. And I already mentioned and highlighted some of the issues that we have with evaluation, reference standard and others, when thinking about AI use for evidence synthesis. But at the same time, I think it is important that while for the time being, we probably should focus on accuracy metrics, and there are other elements of a thorough evaluation which we need to take into consideration eventually, like reliability metrics, efficiency metrics, usability metrics, and a proper risk assessment. And if you look at the literature so far, it's mostly number one. It's mostly number one. Okay, so what are the next steps? And I'm coming eventually to a close here. So Cochrane takes this seriously, and it feels really it needs to be active in this space. And so they have put out a call just 2 or 3 weeks ago, an open call for AI tool developers to come forward and propose their tool for evaluation for some of the systematic review tasks. And the Cochrane or the Joint Methods Group will be heavily involved and take leadership in trying to work together with AI tool developers if they adhere to certain standards in terms of transparent tool development and training sets, etc., to work together with them to thoroughly evaluate their tools for potential use in Cochrane reviews. Okay, having said that, let me just, and that's my second final slide before I come to my conclusions, let me put that into, again, an even broader perspective, because it's not that the only transformation that we might see in the field of evidence synthesis that's happening right now is only AI use. About a year and a half ago, a few people from leading organizations came together trying to think, also based on experiences in the pandemic, trying to think through how actually a fit-for-purpose global evidence, equitable evidence ecosystem should look like. And they came up with some features and characteristics of such an ecosystem, which led the Wellcome Trust to provide some funding to develop a roadmap towards such a fair, equitable, global ecosystem that really answers in a timely manner relevant questions that also help us advance sustainable development goals. And that led to that call for action, which was recently published, which basically lays out a 5-step approach in how such a global evidence ecosystem could be developed. And that then, and I think that is quite encouraging, led other funders or motivated other funders to join the Wellcome Trust and build together a funders forum, as it's called right now. And just very recently in New York at an UN meeting, they announced that they jointly are prepared to invest $126 million over the next couple of years to really help build the infrastructure and redesign that global evidence ecosystem. And that's where the two things come together. One key element here is, again, obviously AI use, because otherwise, even with the $126 million, we're not going to be able to answer all relevant questions and keep all the reviews up to date. So AI will need to play a critical role, and that's why one key funding piece is going to go into the development of AI tools. So, coming to some conclusions here. First of all, a few take-home messages for those of you who are working in the field of evidence synthesis. Human oversight is critical. Don't use AI without checking what you are doing or what the tool, the large language model, the machine learning algorithm is doing. AI should be a companion, not a replacement. I think for the time being, that is absolutely critical and, in my view, non-negotiable. However, it is okay to use AI, for example, for question development, double-checking data extraction, triple-checking data extraction, as long as you can show that it's not impacting the rigor and conclusion of your results. Key, transparently report. As Kamran said, it might be considered even scientific misconduct if you're not transparent about the AI use. And keep in mind that you are really responsible for all that piece of research. Okay, so final summary. Trying to take a bird's eye view here. In my personal view, yes, I think AI will transform evidence synthesis. partly because AI, and in particular large language model, have the potential to affect all the different steps rather than the classical machine learning algorithms which we had around in the past. But LLMs really affect every step from question development to dissemination, potentially at least. I believe it's going to be gradual. I don't think it's a single step, or that in a year's time we'll do all our review fully automatized. So I believe strongly that it will be human-led and AI-assisted because also of the accountability issue. So the most likely future, in my view, hopefully, we'll have an interaction between AI and human teams, so semi-automated workflows and continuous monitoring of the literature, which will lead to major time savings and more timely outputs. So I think living systematic reviews, a few of them have been around, in particular during the COVID pandemic. I think that will potentially, hopefully, become the norm rather than the exception. We might also see actually improved consistency and comprehensiveness if we get the governance of the AI tools right and implementation. And also we might see new evidence products because it's easy for large language model or other AI tools to just develop interactive summaries, tailored output for different decision makers. So I think there's also a field in that area where AI actually can really assist. Thank you very much. Very happy for your questions.
We're going to move to questions.
Thank you so much, Joerg. It was a very nice talk. And if I could be a little bit provocative, I would say it would be also fair to say or to compare the risk of AI and the risk of not using AI for evidence synthesis. Because we know that not using AI, we are absolutely unable to deliver evidence synthesis for each question at good time and so on. Therefore, my feeling is that perhaps there is something about that. In addition, I am not sure that the comparator must be Cochrane, because Cochrane is theoretically the better performed evidence synthesis, rather than, and there is a lot of other evidence synthesis, meta-analysis performed by others that are far from being perfect.
Yeah. No, thanks, Philippe, for the questions. I certainly would agree that there is also risk of not using AI, and that needs to be considered, absolutely. To your second point, I agree that there are many reviews out there that are of poor quality, but I try to be an optimist and think positive. So my personal goal would be that this is an opportunity that we should use to actually increase the quality of reviews, rather than saying, look, if AI gets it as good as poor quality reviews, let's use it. But maybe I'm misunderstanding. But I think that isn't really a good approach. I think we should embrace it as an opportunity to increase the quality, in particular because we know that we have so many poor quality reviews that also inform practice. And I think that doesn't feel right to me.
And my second point is about the outcome. I'm not completely sure that all the outcomes that are proposed are not surrogate outcomes. And in fact, the main outcome for me is the time without a good quality evidence synthesis, for example. And it's probably something like that that would be perhaps the more relevant for physicians, decision makers, and so on. Assessing the whole process, in fact.
Yeah, and again, I would agree, obviously. It makes sense to also look at the impact on healthcare eventually, but I think that is just more difficult to measure. And like in many other studies, I think people tend to measure what they can measure, what is more easily to calculate, to present, than invest in these kind of things. But you're right, I think at the end of the day, that would change the assessment, even if measures are low and not that convincing, if in the longer run they are improving healthcare because they just provide the information at a time, even if it's of kind of moderate quality, but they are improving healthcare and patient outcomes, surely that's the way to go. So I would absolutely agree with that.
Yeah, thank you so much for this talk. I was wondering if you are aware of any initiative or ongoing work trying to develop kind of living benchmark of those LLMs, because so you showed us 2 examples with Claude 2, but like there are plenty of other alternatives or choices and newer ones. So like something which is like always trying to keep up with the release and evaluating, assessing all these tools with the same the same benchmark.
No, again, very good question. So I think it's somewhat just by chance that 2 of the examples use Claude. It had to do that at the time. I believe Claude was the one LLM that actually was able to access large PDF documents if you would just uploaded them, which ChatGPT 3.5 at the time, I think, just couldn't handle that easily. And the other point to make probably is that the models that have been used in the examples seem dated just because it just takes so long to eventually publish a paper, right? So I think you're absolutely right. We need to figure out ways to actually test the current models and come up with an understanding of their capabilities and how to use them responsibly, rather than waiting 12 months until we've written up the paper, it's been published, and based on that, then eventually just make a decision. And maybe just to add to that, one of the other pieces of work that's ongoing in that joint methods group is to develop kind of a reasonably generic standard evaluation framework that then can be easily adapted to specific tasks and or specific tools, so that at least some time is being saved in the protocol development phase, and people can just basically take it, adapt it slightly, and get started once a tool is being released. But at least personally, I'm not aware that people have thought it through really how to then, except for a preprint, share the results very quickly and use that for decision making in terms of making tools accessible.
Hello, thank you for your interesting talk. It's nice to hear a lot of people saying that we will not be replaced by AI tools, but I can't help but think about the difference in terms of qualities between the open access tools and the paid tools. So is there a worry in creating inequality in research also? Thank you.
Yeah, again, very good point, and I mentioned that as a risk, the proprietary models, and which carry certain risk, but also obviously impact on accessibility and equity. I guess the one thing that I can say is that it's one of the prerequisites within the welcome funding call and the wider funder forum that they require both all tools to be openly available, but also all data. And that is a specific issue where Cochrane also grapples with right now, because whatever will be produced with funding from that funders forum needs to be open access and accessible. So my hope would be that eventually at least some of the tools, and I also would think that that would be a priority for Cochrane and others to evaluate these kind of tools that are openly accessible rather than proprietary tools, which have all the access barriers.
Thank you for your very nice talk. So I have kind of 2 questions. The first, some part of your critiques are related to the fact that it may not be reproducible or that it is proprietary, but somehow one way to solve it would have to be like publicly owned or state-owned or whatever owned compute infrastructure with open weight models, and then it would be reproducible. I mean, I have an impression that part of your criticism are not based on the technology, they are based on the political, economical organization of large, of how LLM technology is made available. And I will do the 2 questions in once. And the second one is, you are benchmarking the tools. So each time a new LLM will be put out on the market, it will contain your training, it will contain your test set, it will contain your benchmark. So new LLM will essentially perform absolutely perfectly on your benchmark and on the data you are using to assess. So that means that you would have to design to keep up the rhythm of publication or availability of new models to be able to assess them. So how would you do that?
So I'm not sure I got the first one. The acoustics from that side is somewhat better about the criticism and the reproducibility, right?
Yeah, if the weights are openly available, and you own the compute infrastructure, you can run the version you want. You have the weights, so it will be reproducible. It is not proprietary, and essentially nullify part of the criticism, which are not related to the technology, which are related to the politically economical context in which the LLM technology is deployed.
Yeah. No, if I get it right, I would agree. It's not necessarily related to the technical capabilities of the LLMs. But there was a second part of your question.
So essentially, each time a new LLM is released, it's trained on the whole internet. So
Yeah.
you contain all your benchmarks, all your tests, everything. So it's likely that new LLM will perform absolutely perfectly on your benchmark. So
Yeah, to be honest, I don't have an answer to that. It is certainly a problem. I think people, if you have a suggestion, I'd love to hear that.
one technique people use currently is to design some kind of worlds where the LLM are kind of vague, but I don't know if it's relevant for that. It's one word.
Thank you very much for your presentation. I am using AI. I'm extracting information of many RCTs right now in my project, and I'm reading the papers about using AI-assisted extraction tools. I was wondering why the outcome is, rather than comparing it to the human, it's not to see how it changed the results in the final meta-analysis and the final, and how much you think that the topic that it's being studied could play a role in the accuracy and how well AI can work. I can imagine a paper who would discuss that AI is good in extracting information, for example, when we are talking about a continuous outcome or these kind of recommendations. Thank you.
So I hope I got it right. So two parts of your question. One is that an important outcome might be to just look whether AI-assisted data extraction affects your conclusion. Again, I think that is, or that would be of, let me put it maybe this way. I think it would be of great concern if it affects your conclusion. And I think as scientists, we still usually strive to, first of all, get it right and be precise. And I think that is a reasonable goal for the time being. But still, I think if it turns out that in 100 scenarios, in 100 use cases, it doesn't affect conclusions. And at the end of the day, it is, we acknowledge that we are not interested in the precise effect estimate any longer. We're just interested in the conclusion because that's what matters for decision making. That might be fair enough, but keep in mind that for the decision making and the clinical decision, it's about the balance of all the different outcomes and effects that we are seeing, right? And to get the net benefit right, we need to have some effect estimates. So I'm not convinced that it would be okay to just say, look, we want to know whether it impacts mortality and some kind of morbidity somewhat qualitatively, and then just based on that make our decisions. It might work in instances, but maybe not in others. And the second part of your question, if you might...
How the field, the topic plays a role.
good point. And I would agree. I think many of the studies that I'm aware of usually look at more simple use cases, not necessarily complex ones. And there might be quite substantial differences in what kind of data, what kind of study context or clinical field, what kind of study designs actually data extraction has been used. And I think we need to do more validation work to really better understand where does it work and in what kind of scenario do we actually, can we safely implement a given tool.
Hi, thank you for your presentation. It was really clear. I have a question. So you showed how some steps can be improved or semi-automated with LLMs. But are you thinking of completely different things that we can do for it, because the current workflow has been built around the constraints? For instance, we choose to have a double human review because we know that humans do not agree, but we cannot afford to have 20 humans assessing the risk of bias. But maybe with LLMs, we can have 20 LLMs assessing the risk of bias, and in the end, see which studies are always rated low risk of bias, high risk of bias, where there is uncertainty, and maybe same for the screening, and in the end, have many estimates to go beyond the statistical uncertainty.
Yeah. Again, would agree. I think what I've shown you, which is mostly based on what has been published in that field so far, takes a rather simple approach by just using one LLM, sometimes an outdated version by now, and looks at the capabilities of that LLM. But I'm aware of a few ongoing studies where people actually, as you suggested, combine different LLMs or run several repetitions of asking the same LLM the same question, then take the median or whatever kind of average of that assessment. And I think we need to become more creative in really figuring out what is the best way. But again, I think there's also the downside of kind of energy consumption. It's not that I think we should kind of become extreme about that and just say, look, we run a simulation asking 1,000 times ChatGPT, 1,000 times Claude, 1,000 times Llama, and then we kind of average that. And that's also complex to evaluate, and I think it's not necessarily the right way to go.
So just one last question before we let you go take your train. So you talked about clinical practice guideline using systematic review that we need to make sure that they're, well done. But actually, most clinical practice guidelines are doing a systematic review in 3 months with a lot of pressure, because they have to provide an answer very quickly, and I'm not doing all the work Cochrane is doing. So if you consider the current system in decision-making, it's not true that the current system in decision-making is relying on high-quality evidence synthesis. So having AI with some limitations could possibly also improve the way clinical practice guidelines are being performed.
Yeah, I mean, I think it goes a little bit in the direction that Philippe already mentioned, that there is certainly a risk in not using AI or being very slow in kind of just summarizing evidence. But I mean, it's not often it's not only the step of summarizing the evidence that is slow in getting to a guideline, but it's also guideline processes that are very slow, and which also potentially actually could be improved by AI. Haven't spoken about that, but work is ongoing on kind of doing the grading with AI and stuff. So yes, I think the answer is yes. But again, I think we would need to figure out somewhat thoroughly what is really the trade-off, right? For now, I think it's an assumption. I would agree with that assumption that there is harm in being slow. But I think in getting it wrong and having then at the same time getting it wrong based on the assumption that we are getting it right because we've done a systematic review with AI, and then maybe not being prepared to change that and adapt that conclusion is also a certain risk.
Well, thank you very much for this
Thank you so much.
presentation.